Welcome back to the Physio Foundations podcast for another week, the podcast where we talk about the knowledge and skills that provide the foundation of expert clinical practice. So this is part 2 of a series on clinical communication that I'm doing, and today Zuzana's joining me to discuss the 10 tips that I gave you in part 1. So if you haven't listened to part 1, there you go, cue it up for next time or go back and listen to that one first. So Zuzana, welcome to Physio Foundations again.
Thank you for having me.
Always good to have the wife on, and not just the wife, but an expert in the field. We can pick your brains on many, many things. So let's talk about some of the points. Let's get straight into it. Let's talk about some of the points I made in part 1. And what I want to do here is get your perspectives on, as someone who's worked, someone who's in many ways mentored me on a lot of these things. A lot of these ideas are yours, or they're the result of many conversations we've had over many years. And they're also, they've come from my teaching experience as well. So there's more than one place they've come from. But the first thing I talked about in episode 1 was, and it was titled The Problem with Clinical Communication. And I made the case that the problem with clinical communication was that it's really hard to know when you're not being understood, unless you're reflective, unless you think about it and pay attention to that. And everyone thinks they're a good communicator. And even if we don't feel comfortable communicating all the time, there's always a feeling that we've made a clear point and we may have not got our message through to everyone, but essentially we feel like we're being clear even when we're not. And I talked about the curse of knowledge, where you can become very familiar with something, and as a result of your familiarity with it, it becomes more difficult to remember what it was like when you didn't know about it. So I thought we'd bring you in on this one. And what I'll do is go through the 10 points one by one, and we'll get your perspectives on them. The first point that I made, the first tip actually, no, rather than the point, the first tip I had for effective clinical communication was, number 1, explain what you want to do and why you want to do it. So the point here being explanation, and not taking it for granted that someone else understands what you want to do and why you want to do it. And what are your thoughts on that?
Well, I mean, I'm lucky enough that I get to see, I'm at that point in my career that I see a lot of people that have tried other avenues, other clinicians, and probably haven't gotten to where they wanted to, and so have been referred to me by colleagues of mine or friends and other professionals. And the one thing that I do get consistently is, I go through, at the end, the treatment and the plan, etc. But I like doing a lot of education, and I'm a very visual person. So I'll often have the computer up and I'll Google images and talk to an image whilst they're there. And I get a lot of people comment and say, now I understand why I should be doing, X, Y, and Z. No one's explained it to me like that. And it's just more, I probably haven't done anything different from the previous clinicians. But the reason why maybe I get better results is because I at various points or multiple points, I ask the patient, ask them, do you have any questions, and do you understand, where this is going? And also I try to tailor my education to their particular situation. So if they're having troubles with something, then, I will pull that out. For example, I had a patient just on the weekend actually who had multiple areas of concern, and he'd seen multiple professionals individually for each one of these concerns. And he was sort of at his wit's end because no one could help him. Then he saw my colleague at sports medicine, or I work in a sports medicine clinic, saw the sports physician who referred him to me. And, I just went through everything and I said, okay, there's, and got a really good subjective, had a look at his objective, and then was trying to piece things together and then just letting them know what I was thinking. And he just looked at me and he said, oh, that's the first time anyone's actually, linked my, presentations together, and it makes sense to me. So that's really powerful, because now whatever I, give them, they're going to be more inclined to do it because I put it to their presentation. The other thing, and I'm quite lucky that I helped tutor on the GLAD course, which, if people don't know, is the Good Living,
Arthritis Denmark.
With arthritis in Denmark. Yeah, it's a really great program. It's got education, exercise, all sort of put into one. So it's really empowering the individual through education so they can understand the intervention and what they can do, etc. But where I was going with it is one of the things that we teach on the course is the teach back method. And right. I don't know if listeners know what that is, but it's really a very useful and a powerful tool to use in the clinic. And it's a way to confirm if the patient understands you by using their own words. So pretty much you give them the education, and then you ask them to tell you, what have you said, can you say it back to me? So, for example, if you give someone an exercise prescription, say, okay, I want you to do, let's say, 10 sit-ups 3 times a day. And then you look at them and say, now, what are you going to do with these sit-ups? You tell me, and then get them to report back, oh, well, I'm going to do sit-ups, et cetera, 10 times, 3 times a day. Or they might say, I'm going to do sit-ups every 3 days. And you go, no. And it gets you to clarify what you have said. So the other thing, and I'm sorry, we're on point number 1, so I don't know how far we're going to get into it.
This is good. And what we might do actually is break this into part 3. So we might do whatever we can get covered today in the time we've got, and we might come back and do part 3 of this conversation. And there's going to be part 4 and 5 and 6 because I've already talked Joe Corbett from Monash Uni into a podcast episode, and I've got many people who want to talk about this stuff. So we'll get through what you want to focus on. Okay. It's fine.
So the other thing is understanding that a patient may not be ready to hear what you have to say. And it may mean that you need to say what you need to them multiple times. And it's the same in teaching, as you would know, that, the important points you want to repeat multiple times so that they sort of sink in, because no one really gets it the first time.
That's really important. Just to sit here and reflect on that and realize that, well, that's so the case for me when I'm learning something, that I need to hear it multiple times. Of course, patients, of course, students need to be hearing it multiple times from multiple different people in multiple contexts.
And again, I'm guessing I'm just adding GLAD as an example here. But again, what we teach is, sometimes what you want to do is put the education session first, so that, it's got a lot of education on, what is osteoarthritis, the anatomy, and getting the loads right for the joint, et cetera, et cetera. And you might want to do that first before you do the intervention. So the time where you're doing some prescribed exercises. And what that does, rather than, because there is no prescribed time to do the education, but if you do it first, it's the first time they hear it, but they're not going to necessarily get everything or take in everything. So then you're going, because they're supervised sessions, you've got that opportunity that when they're in the session, you can start saying some of the key points again and say, oh, remember when we were talking about A, B, and C. And then they go, oh, yeah, now I remember. And then they can sort of reflect. There's been so many times where someone has come in and I've taken these GLAD sessions, these exercise sessions before, and they've come in, and their knee has flared up and, I've already done a few sessions and they say, oh, look, I wasn't sure whether I should come in because the knee's, not feeling that good. And say, oh, well, remember what we talked about with flare-ups, it doesn't mean that you don't do exercises or you don't do the intervention. We just modify it. Now, oh, yeah. So they, because they're still in that, previous mode where, if their knee did swell up, they'd, rest it and wait for it to settle down before they started again. And, you get that boom, bust, boom, bust. And again, when you're talking about it to them about the boom bust, they're sort of, oh, yeah, that's not me. But then when you have that opportunity where they have done it and they come in and, oh, remember when we talked about, so it just gives them, just remember that whatever you say. And that's the other thing is you have so many, and I think you've talked about it on your podcast before, where you've had, patients have come from other professionals and they say, well, what have you tried in the past? And they'll say, oh, I've tried this and it doesn't seem quite right. Like it doesn't sort of add up. Let's say the physio just said massage was the only way to fix, I don't know, an ankle sprain.
I think I've talked about this in one of the first episodes with Pete Maliaris, and we made the point you weren't there and you really don't know what went on, but sure, we'll listen openly. They did. They spent 45 minutes with you and did massage. Okay. Nothing else? No other assessment? I don't know. I'll give my colleagues some more credit than that, but go on, I'll listen.
Yeah, exactly. And so again, that's why it's important to explain what you want to do and why you want to do it. So that they get that meaning from it, so that okay, you're doing massage now, and then whilst you're doing, and that's the other thing is if I do hands-on, I don't often just do hands-on and that's it. When I do hands-on, I find that's the perfect opportunity to do some education, and also further the subjective in terms of trying to figure out the context of this person's situation. For example, I had someone with their, it was a shoulder, and we talked about, all the aggravating, easing. We did a nice subjective. Then I was there doing my treatment after the objective, and he just sort of, I think I must have said something about, it does, when you have pain for a long time, there is an element of, depression that can come with it, because we're not used to having pain for so long, and it can really wear you down. He goes, yes, it really wears me down because I can't bowl to my son, cricket, because the son plays cricket, which is, a sport. I don't know if everyone knows it, but there is an action where, there's a bowler who throws the ball. Well, obviously, no, you throw it with a straight arm.
Trying to talk to the international audience here. So cricket bowling with a straight elbow and at high speeds, a lot of force through the back and the shoulder. Yeah. And that's when I said, okay, well, that's your goal. And he said, what do you mean? I said, all right, we'll assess how we're progressing with your rehab with how you can bowl to your son. And within 2 weeks, he was bowling relatively pain-free to his son. So not only did he have that goal, but he knew that's where he was aiming. So the rehab exercises gave more meaning to why he wanted to do them. And I think that helps. But let's go on to point 2. Well, you've given us so much there to think about. So as a bit of a summary, so the points we're talking about here were actually number 1 and number 10. So number 1 was explain what you want to do and why you want to do it. And number 10, which you touched on, was linking to the person's condition, actually linking all the technical stuff we do and all the communication. Make sure you're linking it back to that person and their goals you mentioned. And you talked about the value of repeating information and how it does take time to sink in and repeating it in different contexts. And then the trick of getting people to repeat back to you to summarize. And then you went a little bit deeper into what you might do in some of that dead time. Perhaps you're doing what might be considered a low value treatment if we're writing it down and looking at literature, some soft tissue therapy or something, making that high value by reflecting on the person's motives and that perhaps their mental health or any other contextual factors. And and then you were in that example of the guy who wanted to bowl with his son, talking about exploring their goals further. So you made quite a lot out of 2 points. It was very good. And we've only got a few minutes left before you've got to go to your next meeting. Point number 2 was that I made last week in the last episode, or tip number 2 was no jargon. And jargon is technical terms and industry specific terminology and things that make sense to you and probably don't make sense to someone else. And they feel good to say because you feel smart, and they don't feel good to listen to. Your perspectives on jargon. I mean, can you explain the concept to a 5-year-old where you really can't use jargon? That was my example from last week. When can jargon be a problem? How do you get around it or avoid dropping jargon on people? What do you do in the clinic?
Well, often I ask them, a lot of people, a good example is, I've been working out on my core because I know that that's important for my low back pain. And you just go, okay, what is your core? Oh, it's muscles. Okay, can you tell me which ones? I have no idea. I just sort of sit there and go, and so, then I'll talk about it. I like to, talk about the deeper unit. And look, I might be old school looking at transverse abdominis, pelvic floor, diaphragm and multifidus, but I do use those examples and talk about it. And I talk about, you've got that global unit that helps you move, and then you've got the inner unit that helps with that stability so that, you can move on something that's stable, gets you stronger. And it's, a classic example is, the ones that are strong in that inner unit, if you watch football, for example, and someone gets tackled, if they're not strong, they tend to get tackled and they just fall to a heap down on the ground. And the really good players with the really nice core, they get tackled and they almost sort of just swing their hips, and the player that's tackling sort of goes flying because, they can control it. And it's a really nice example of, getting their understanding of what it is. I had a young girl from the weekend. She's been having problems in her sport, and she's been given all these core exercises, which are all lying down. And, the core is what you need. And, there you go. And that will fix it. And she didn't really know what the core was. So we sort of talked about it, and that, yes, she was doing the right exercises. But it was interesting because in her sport, she has to do a lot of running. And I said, okay, can we have a look at your running? And I had her running, and her father was with her. And I sort of went, oh, okay, well, I can see your problem. And just like, oh, what's my problem? And I looked at the dad and I said, look, I'm sorry, but I'm going to have to give it to your daughter straight. You're running like a model on a runway where, they have that excessive pelvic, movement, etc. So we know that even though you're doing these exercises, these core exercises, you're actually, not using them for when you need them for your sport. So,
there's an art of connecting with someone with maybe even the politically incorrect or something that someone else wouldn't get away with, and just knowing how to connect with them. How did that end up? Was it taken badly or well?
The father said you're the physio for us because we like someone that tells us straight. And the daughter was laughing and said, I understand what you're saying, and it's true. And then we worked on it. And again, she felt the difference. She felt how much more powerful she was by focusing on, the exercises she was doing. And then she was able to, take that feedback without the jargon. So rather than me saying, there's a lot of pelvic movement there, you've got a lot of lateral sway and all this other stuff, and there's internal rotation here and external rotation here. I just said, you're just running like a model. I had one of my friends from uni, I remember she was saying, again, a physio, and she said, don't you hate it when they keep asking you lots and lots of questions? And I said, what do you mean? She goes, I just get sick of it. And so I just put as much jargon as I can at them to stop them asking questions so I could just keep on time. And I thought,
Yeah, okay. So what you've done there with the jargon is you've sort of flipped what I was saying last week on its head. I was talking about that jargon coming from you as a clinician and not being aware of that it's not being understood, or that there's probably more plain language ways to communicate things. And you're right. And jargon can come from Dr. Google, from the community, from patients themselves. And so what you did there in a quite patient-centered or person-centered way was just sort of challenging them on, do you know what that means? And then you mentioned being old school, and you mentioned some concepts from multifidus and TA and things that, on their own are going to come across as being old hat. And then what you actually did is took the patient's existing knowledge there and their understanding, their conceptual framework about what's going on, and then presented what they do in their running with what they already understand already. And then you didn't just get them to lie down there and do some exercises lying down. When they're a runner, you got them up and got them running. I just want to make the point that a lot of that, the intervention you eventually did and the exercises the person does and is compliant with, to use that word I don't like, actually came through solid clinical communication. And sometimes knowing where the edge is and knowing where you can be, politically incorrect, or maybe a better way to put that is where, knowing where the edge, when you can play and maybe have a bit of fun and have some humor as well without overstepping the line.
Even, talking about someone that, they're walking and their issue is that their leg goes into, adduction, or, they got that Trendelenburg and they're dropping, and, trying to tell them that. Like I had a nice lady on the weekend, and I just said to her, I said, do you like walking on a tightrope? And she said, what do you mean? I said, because that leg that keeps coming in, like as if you're trying to go on a rope. And she's like, I've never noticed that before, And again, I could have said, your leg's falling into adduction and all that sort of stuff. And also the other thing where jargon is a big one is when, people come in with their MRIs or X-rays or whatever investigations they have, and they often have a report and they have no idea what this report means, and also which bits of the report are relevant. So being able to communicate what, translate the results, because if they've brought it in, it's meaningful for them. So I think that there's been this big issue of, you've got to marry up the results with the clinical findings, and they often don't, relate to each other. So sometimes, we don't look at the report. And I think what's unfortunately been happening is people bring in a report and the physio or clinician will just go, we don't need to look at that. And just put it off to the side. But if someone's brought their report in, brought in their MRIs, it's really powerful if you then acknowledge it, because it's meaningful for them, and to go through it. And I will often then get like a model of a knee, model of a shoulder, and I will actually point out on the model, if they've got medial compartment, whatever, I'll show where the medial compartment is. I'll show where the labrum is. I'll show,
So talk through that jargon that's written in the radiology report one by one and actually say, this is what this is. So you're acknowledging it.
Exactly. And it makes a huge difference for them. But also then you're able to talk about the normal findings, so some degenerative changes. Oh, okay. That's like, when we get older, we get grey hair. Are we going to be worried about the grey hair? No. So there's some changes that are normal with the aging process. And, one of the most powerful examples I had of that was one of my colleagues. He had a low back pain patient who came in and was just crippled, like just bent over, shuffling in, lots and lots of pain, almost in tears. And he's just said, what's going on? And he's looking at the report. There wasn't a lot, a lot of findings on there. And the GP just sent this fellow over, and he said, my spine, it's disintegrating. I said, what do you mean? It's written on the report. I've got disintegrating spine. And it's like, no, you've got degenerative change. It's not disintegrating, And
you can forgive people for coming to that conclusion. You've got 20 years of experience, and then they've been given this out of context and expected to process it. So this is such an important part of our job to help them do that.
Yeah, and that clinician then spent most of his time just educating and bringing up some research so that it wasn't just coming from him. So that's the other thing that can be really, really helpful is your guidelines and other research, so that it's not just coming from you. You can say, oh, look, this is what the recommendations by this guideline are, whatever. So say your osteoarthritis guidelines, there's quite a few which, recommend your exercise, your education, your weight management. So that's why you're asking about weight management. A lot of them will have recommendations on things that patients often want to know about, what are those injections, should I get these injections? So, and that's where you can go and refer to these guidelines rather than, well, I think, which not necessarily they're going to go, okay, well, I heard from my friend and they had them and it worked well, so why don't I go?
It's a really good point. It's not just an appeal to authority by talking about literature and a guideline. What you said before is that explains why you're talking about that, which is the point we're talking about. Explain why you need to ask those things, because we know, for example, weight management is important and it's in the guidelines. This is why we're talking about it, rather than just asking a whole bunch of questions because you know why you're asking them and just assuming the person understands why you're asking about weight management when you're talking about knee osteoarthritis. I mean, you do need to make the connection between the two things, and that was a really good example of how we do it. That beeping everyone heard before was your other colleagues, your research colleagues, wondering where you are because you've got another meeting there. So, but that's good because we've got more to cover. We're going to go through more of the technical aspects of communication and sort of how they're linked together with exercise prescription and manual therapy and physical examination. We're going to talk about consent, pet topic of mine, and we're going to talk about talking the person through what you're doing while you're doing it and investigating with your communication, monitoring the effect of interventions, warnings and queuing and summarizing what you found. So there's plenty more to talk about, but I'm going to wind it up here. So on behalf of everyone listening, I'm sure that everyone's found that really valuable. Thank you.
Thank you for having me again, and catch you on the next one.
So that's it, everyone. So please start putting these ideas into action. And when you do, just let me know. Let me know how you're going. I do want to hear from you as a podcast listener. Please keep the emails and the messages coming that I've had. I'll do some shout outs when I can, and leave a comment, send me an email, like, subscribe, all those things we always ask you to do. But until next time, this is Luke and Zuzana wishing you all the very best with your studying, professional development, and lifelong learning.